of prolonged post-operative sedation and ventilation. One minute. Space-occupying lesions such as tumors, intracranial hematomas, and abscesses are the most common indications for supratentorial surgery. Supratentorial tumors are more common in adults and present with headache, seizures, or new neurological deficits. Infratentorial tumors are more common in children and present with obstructive hydrocephalus and ataxia. Gliomas and meningiomas are the most common primary brain tumors. Now let us first discuss the anatomy of the supratentorial region. The tentorium cerebelli separates the supratentorial compartment from the infratentorial compartment. So this is the supratentorial and this is the infratentorial compartment. The supratentorial area contains the cerebrum, lateral ventricle, third ventricle with CSF, choroid plexus, pineal gland, hypothalamus, pituitary gland, basal ganglia, and optic nerve. Then the two cerebral hemispheres are separated by the falx cerebri, and each hemisphere is further divided into 4 lobes: the frontal, the parietal, temporal, and the occipital lobe. Now, what are the types of lesions? They can be within the brain parenchyma, they are known as intraaxial lesions, or they can be external to the brain parenchyma, known as extraaxial lesions, or they can be intraventricular lesions. So the most common lesions are neoplasm, which can be primary or metastasis. The primary lesions are glioblastoma multiforme, astrocytoma, primary central nervous system lymphoma, ganglioma, and oligodendroglioma. They can be lesions because of abscesses or neurocystic or hemorrhages. Now, extraction lesions again can be due to neoplasms like meningioma, hemangiopericytoma, and pituitary tumors. They can be lesions due to hemorrhage like subarachnoid hemorrhage, subdural hematoma, extradural hematoma, or due to arachnoid cyst. Now, the intraventricular lesions are the neoplasms of the ventricular wall and the septum pellucidum, ependymoma, central neurocytoma, choroid plexus papilloma, or carcinoma, and intraventricular meningioma. There can be colloid cyst or infections like hydatid cyst, tuberculoma, or neurocystosarcosis. Now, what are the clinical features in patients with supratentorial lesion? They may complain of headache. This is because of the dural inflammation or irritation. They can have history of seizures because of cortical irritation. Focal neurological deficit if the tumor or the resulting edema presses on a specific portion of the brain parenchyma. If they involve the precentral gyrus, that is the motor cortex, or the postcentral gyrus, which is the sensory cortex, there can be motor or sensory involvement. They may present with signs and symptoms of raised intracranial pressure like headache, nausea, vomiting, ataxia, syncope, and visual and cognitive impairment. The diagnosis is done with CT and MRI. Now, how do you assess these patients? In the preoperative evaluation, look for the signs and symptoms of elevated intracranial pressure. Perioperatively, factors which those patients who are already in the decompensated phase, you have to take care, or in the compensated phase or already in the extreme position, you should take care that you avoid factors which will increase ICP. Their use of osmotic diuretics, contrast agents, and decreased intake can cause electrolyte and fluid imbalance. So evaluate the hydration status and the electrolytes. If they have focal neurological deficit or seizures, document them. Assess for the coexisting medical condition, and especially the cardiorespiratory condition should be optimized prior to surgery for optimal cerebral perfusion pressure and oxygenation. Then the primary site of metastatic tumor should be sought for and identified, because previous surgery, chemotherapy, and radiotherapy may affect the anesthesia management. The cerebral abscesses can be due to infection of the middle ear, paranasal sinus, or dental infection. They can be because of the hematogenous spread from chronic infective lung disease, subacute bacterial endocarditis, or cyanotic congenital heart disease. And in immunocompromised patients, there can be multiple abscesses. So we have to take proper aseptic precautions in these patients. It's important to evaluate the level of consciousness If their level of consciousness is depressed or they have impaired cough or gag reflex, there is chances of sputum retention and aspiration pneumonitis. Again, because of decreased level of consciousness, hyperventilation can result in basal atelectasis, which can lead to hypoxia, hypercapnia, and worsen the brain swelling. The surgical approach, patient position, tumor vascularity, and anticipated difficulties should be discussed with the neurosurgeon. Dexamethasone is usually administered for tumor-associated vasogenic edema, but one must keep in mind that even a single dose can significantly increase the blood glucose concentration even in non-diabetic patients. Patients who are on prophylactic or therapeutic anticonvulsant, the plasma levels should be checked prior to surgery. Otherwise, if the levels are reduced, there can be chances of perioperative seizures, and also the requirement of neuromuscular blockers are increased. Patients on diuretics like mannitol and furosemide, there can be risk of hypovolemia and electrolyte imbalance. So what are the investigations one should ask for? One is the full blood count to know the hemoglobin. So whether in a vascular tumor, how much of blood should be grouped and cross-matched. In patients with tumors, they can have increased incidence of thromboembolism. They may be on low molecular weight heparin, so the clotting screen should be individualized. The renal functions can be impaired due to the use of osmotic diuretics, diabetic insipidus, and many other conditions. So BUN, creatinine, and electrolytes are important. And I've already told you the blood glucose may be raised as a result of preoperative steroids. And if there's a potential for intraoperative risk of bleeding, blood grouping and cross-matching should be done. In X-ray, just look for infections or the primary site of tumors. If the brain tumor is a metastatic tumor, increased ICP or subarachnoid hemorrhage can cause ECG changes. And you must do the study of the neuroimaging, whether it is CT or MRI, to know the location and size of the tumor, whether it is involving any eloquent area or near a major vessel, which can cause bleeding or increased incidence of air embolism. The surgical position depends on the location of the tumor. Then if you know the location, you know what surgical position will be required for the patient, whether there is a potential for blood loss, especially with vascular tumors, or if they're near the major vein sinuses. If there is evidence of midline shift of more than 0.5 centimeters, this will suggest that the patient has increased ICP. And if it's close to the venous sinuses, there can be risk of air embolism. So what are the principles of general anesthesia? The principles are providing optimal operative condition by manipulation of the intracranial pressure. Now, it's important to have a slack brain to facilitate surgical access and reduce the retractor pressure. If there is too much of retractor pressure, there can be local cerebral ischemia and postoperative edema. The other principles are maintenance of cerebral perfusion and oxygenation, facilitation of electrophysiological monitoring, and rapid smooth awakening, which will allow us early neurological assessment. Now, first in brief about the intracranial physiology. As we all know, skull is an enclosed and rigid container. The Monro-Kelly hypothesis states that the sum of the intracranial volume of blood, brain, CSF is constant. Any increase in volume of any one of the intracranial contents must be offset by a decrease in one or more of the others. And mostly it is by the blood or CSF which is pushed into the extracranial spaces, so that it is not associated with an increase in ICP. But once these compensatory mechanisms are exhausted, the further, as you can see in this graph, that once the compensatory mechanisms are exhausted, further increase in volume will result in a large rise in ICP, causing ischemia or herniation. Now, what is autoregulation? For a cerebral perfusion pressure between 50 and 150 millimeters of mercury, the cerebral blood flow is maintained at 50 ml per 100 gram per minute. But if the CPP falls below 50, there are chances of ischemia, and above 150, then there can be hemorrhage or edema. Now, regarding PaCO2, there is a linear relationship between PaCO2 when it is in the range of 20 to 80 millimeters, and the cerebral blood flow also will increase in this range. Hypoxemia increases the cerebral blood flow, and hyperoxia decreases the cerebral blood flow. If the arterial pressure remains constant, the cerebral blood flow will decrease when the intracranial pressure increases. Now, what is the effect of anesthetic agents on cerebral blood flow, CMRO2, and ICP? All intravenous anesthetics except ketamine reduce the CMRO2 cerebral blood flow and hence the cerebral blood volume and ICP, leading to decrease in brain bulk. Intravenous agents also preserve the cerebral autoregulation and carbon dioxide vascular reactivity. But it is important to remember, though intravenous anesthetic agent maintain the cerebral, reduce the ICP, but it's important to remember that you have to maintain the CPP during propofol anesthesia because propofol anesthesia can cause hypotension. So as seen in this, the ketamine is the agent which can increase the CMRO2 and cerebral blood flow, whereas all other agents will decrease the CMRO2 and cerebral blood flow. Now, the volatile agents suppress the CMRO2 and are also vasodilators. But at doses up to 1 mag, the suppression in CMRO2 balances the vasodilatory effects and cerebral blood flow will not change significantly. But when the doses are greater than 1 mag, the vasodilatory effect predominates and the cerebral blood flow will increase. And amongst the inhalation anesthetic, halothane has the most vasodilating property, whereas sevoflurane has the least. The nitrous oxide increases the cerebral blood flow, CMRO2 and ICP, and at higher concentration of inhalation anesthetic agents, autoregulation and PaCO2 reactivity will be impaired. So the cerebral blood flow will be pressure dependent. So this diagram shows you that when the concentration is higher, there will be increase in cerebral blood flow. Otherwise, the cerebral blood flow and the most vasodilating is halothane of all the inhalation anesthetic agents. Non-depolarizing muscle relaxants do not cross the blood-brain barrier and have no effect on cerebral hemodynamics. Suxametinium can cause a small rise in ICP as a result of muscle fasciculation and hypertension, but this effect is transient and clinically irrelevant, and it can be attenuated by giving adequate depth of anesthesia. In difficult airways, securing the airway and avoidance of hypoxia and hypercapnia is important. So suxametinium should be used if there is a difficult airway to facilitate airway control. At optimal doses with controlled ventilation, opioids have little effect on cerebral blood flow or cerebral autoregulation. Now, after seeing what are the effects of various anesthetic agents on the cerebral physiology, let us come to what pre-medication one should use. One must remember that when the patient has increased intracranial pressure, sedation must be given under supervision because these patients are sensitive to they can have respiratory depressant effects due to sedation, and this can lead to hypercapnia and hypoxia. But at the same time, no sedation will cause stress and hypertension, especially in a where the cerebral ICP is not much raised. It can increase the cerebral blood flow, CMRO2 and ICP, and lead to vasogenic edema. So one must take precaution that sedation should be given under supervision. Dexamethasone is required for tumor-associated vasogenic edema or radiation-induced necrosis. Then routine medication, especially antihypertensive agents, should be continued up to the day of surgery. H2 receptor blockers and prokinetic agents are recommended. These patients can have decreased gastric emptying due to increased ICP, or due to the use of steroids, they can have increased acid secretions. And cortical incision and brain surface irritation by retractor are potential foci for convulsions, so they must be administered anticonvulsants. Now, what about the vascular access? If it's a craniotomy, it's preferable to take 2 large bore peripheral venous lines. For stereotactic biopsy, 1 IV access is enough. It's important to take arterial line for tight monitoring of the blood pressure, maintenance of cerebral perfusion pressure, and for arterial blood gas analysis. In the arterial line, the transducer should be placed at the mid-ear level. Now, the central venous, if there is risk of venous air embolism, substantial bleeding, or major cardiovascular compromise, then central venous access should be taken. It can be also useful for infusion of vasoactive drugs. So the right internal jugular vein or the suppliant vein are usually cannulated for central venous access. Now, coming to induction, you use intravenous agents such as propofol, thiopentone, plus an opioid. Induction should be smooth with stable hemodynamics and no coughing or straining, because anything which is if there is coughing or straining during the induction, it can increase the intracranial pressure. So precautions should be taken. Non-depolarizing muscle relaxants are used to facilitate tracheal intubation. Peripheral nerve stimulators are used to confirm that muscle relaxation is complete before laryngoscopy. So at the induction, you have to take care there's no fall in BP, nor there should be hypertension. The hypertensive response to laryngoscopy is attenuated with remipentanil or additional bolus of induction agent or agents such as lidocaine or beta blockers like labetalol or esmolol. If the patient has history of vomiting and delayed gastric emptying, then a rapid sequence induction should be used. These patients, non-kinkable cuff pre-imposed endotracheal tube is recommended, because if the patient has if the head is rotated or there is extreme flexion of the neck, so it's preferable to use a flexometallic tube. Eyes should be covered and protected. Now, coming to monitoring, the goals of monitoring are to ensure adequate cerebral perfusion, maintain cardiorespiratory stability, detect and treat air embolism. As I've already told you, that increased ICP or surgical retraction or manipulation of the brainstem or cranial nerves can lead to ECG changes. So one must monitor the ECG. Other monitoring are the standard ASA monitors like oxygen saturation, end-tidal carbon dioxide, temperature, peripheral nerve stimulator, top guard, central venous pressure monitoring, and invasive arterial blood pressure monitoring. The urinary catheter is inserted to monitor the fluid urine output. Bispectral index and spectral entropy are used to assess the depth of anesthesia. And if the surgery is near the eloquent area, then you may need to use intraoperative neurophysiological monitoring. The various approaches for supratentorial surgeries are, if the surgery is anterior to the coronal suture, then it can be in supine position, where the peroneal or the frontal approaches are used. In bifrontal approach, you must remember that the venous sinuses can be traversed. There are chances of bleeding and venous air embolism. In case of behind the coronal suture, it can be semi-sitting or lateral decubitus position. For pituitary gland, stellar or suprasellar region, it can be through the transsphenoidal or the transcranial approach. As I've told you, most of the supratentorial surgeries are conducted with the patient supine and head partially rotated. One must take precautions to avoid extreme neck flexion or rotation, which can impair the venous return and increase the intracranial pressure. There can be endobronchial migration of the tube, or obstruction of the lymphatic and venous drainage can result in macroglossia. If the head is rotated, a sandbag or an alternative support should be placed under the shoulders to reduce the adverse effects on intracranial pressure. Then 10 degrees reverse Trendelenburg tilt is given, which will reduce the ICP without the adverse effects on cerebral perfusion pressure. Pressure points should be properly padded and the airways well secured. Tachycardia and hypertension, which can occur due to pin, because the pin insertion is quite nociceptive, is quite a nociceptive stimulus. So this can be attenuated by deepening the plane of anesthesia or with interfiltration of local anesthetic. For temporoparietal approaches, lateral position is used. Before surgical draping, the position of the endotracheal tube should be confirmed and the accessibility of the intravenous line should be checked. Now, to provide analgesia and maintain the hemodynamics, you can infiltrate the scalp with local anesthetics and epinephrine, or scalp block can be given. Now, the anesthetic technique, what anesthesia technique will you use for these patients? It's individualized as per particular procedure and patient. You can use sevoflurane or in concentration less than 1 mac, or propofol infusion supplemented with remipentanil. But keep in mind that in patients who are somnolent, vomiting with papilledema, a large tumor mass, and compressed basal cisterns on CT, the intravenous technique is preferred. Anesthesia technique must be modified if intraoperative electrophysiological monitoring is used. Now, how do you optimize the intracranial pressure before dural opening? As we all know, when there is raised ICP, sudden decompression of opening of the dura can cause transcranial herniation and permanent neurological damage. So what all measures we should take to optimize the ICP before dural opening? Can administer drugs like mannitol, steroids. Then CSF drainage can be done through the external ventricular drain or insertion of a lumbar drain, mild hyperventilation to decrease the blood flow, and adequate depth of anesthesia, especially at intubation, head pinning, skin incision, and cranial opening. Major fluctuation in the intraoperative period, avoid major fluctuation in blood pressure. Ventilation is adjusted to maintain normocapnia. To maintain normothermia, hot air warming blankets are used. Blood pressure should be preoperative values before closure of the dura to ensure adequate hemostasis. The goals of perioperative fluid management are normovolemia, normotension, and normoglycemia. In the intact blood-brain barrier, the fluid flux is determined by osmolality rather than osmotic pressure. As we all know, compound sodium lactate is slightly hypoosmolar. The effective osmolality is 250 milliosmoles per liter, so too much of sodium lactate can cause cerebral edema. Sodium chloride is slightly hyperosmolar, but the adverse effects of sodium saline solution, sodium 0.9% saline is hyperchloremic acidosis. So what we can use is alternating bags of sodium chloride and compound sodium lactate. If you have a buffered crystal solution, if available, whose osmolality is approximately 270 to 294 milliosmoles, is ideally recommended. Blood loss should be replaced with colloid and blood products to maintain a hemoglobin of more than 8 grams per deciliter, 8 grams per cent. Glucose-containing solutions are avoided because the residual free water worsens the cerebral edema and hyperglycemia exacerbates cerebral ischemic damage. Now, to reduce the brain bulk, intracranial pressure, and the brain bulk, there is a concept called the chemical brain retractor concept. And this in chemical brain retract concept, there is use of mild hyperosmolarity with 0.9% saline as baseline infusion, 20% mannitol, 0.5 to 0.75 gram per kg, or hypertonic saline, 2 to 4 ml per kg is administered before bone flap removal, and normovolemia is maintained. Intravenous anesthetic agents are preferred like propofol. We can use mild hyperventilation and mild hyperoxygenation, mild controlled hypertension. Mean arterial pressure is maintained around 100 millimeters of mercury because this will cause a vasoconstrictor cascade, and this decreases the cerebral blood volume and the intracranial pressure. See that no vasodilators are in use. Head-up position is given so that there is unimpeded cerebral venous drainage. There should be no compression of the jugular veins. Minimal PEEP is administered. The depth of anesthesia should be adequate, and muscle relaxant should be given to prevent bucking on the when you are ventilating. Lumbar drain can be inserted, and this will all help in avoidance of or minimal use of brain retractors. So this is called the chemical brain retractor concept. Now, what is tight brain during surgery? Now, adequate brain relaxation, as I've already explained to you in the previous slide about the chemical brain retraction concept, is required to facilitate neurosurgery and decrease the need for excessive brain retraction. If the brain is tight, there is risk of ischemic injury. It can interfere with surgery and even prevent closure of the dura. Now, there are 4 compartments: the blood volume, the cellular compartment, fluid compartment, and the CSF volume. If there is an increase in any of the compartment, it can increase the intracranial pressure and cause tight brain. Now, the components which are under the control of anesthesiologists are marked with asterisks. So increased blood volume can be due to increased airway or intrathoracic pressure, decreased jugular venous pressure, hypercapnia, hypoxia, inhalation anesthetic agents which cause vasodilatation, vasodilators, and seizures which can increase the CMRO2. If there is a hematoma tumor, it's because of if there is a mass lesion like tumor or hematoma, again there can be increase in the intracranial pressure. The increase in fluid compartment can be due to edema, or if there is increase in CSF volume like in patients with hydrocephalus. So what are the predictors of intraoperative brain bulge? Preoperative intracranial hypertension based on history, symptoms, and signs, imaging studies, and ICP measurements like history of headache, nausea, vomiting, change in mental state, papilledema, pupillary dilatation, decerebrate posturing, and bulging fontanelles or scalp flub will all indicate that these patients have increased ICP and they can have more incidence of intraoperative brain bulge. And on computed tomography scan or the CT scan, there can be edema, shallow sulcus, midline shift, and compressed basal system. All this will predict that the patients will have intraoperative brain bulge. Now, there should be a systematic approach when you have a high tight brain in the intraoperative period. So what is the checklist for high intracranial pressure or tight brain? So one, we must ensure that the other relevant pressures control, that is jugular venous pressure, there is no extreme head rotation or neck flexion, there is no direct jugular compression, and head is given at least 10-degree head tilt. Airway, there is no increase in airway pressure due to airway obstruction, bronchospasm, straining coughing, patient is not adequately relaxed, or pneumothorax, especially when you have inserted the central venous line. So there can be incidence of pneumothorax and increase in airway pressure. The partial pressures of carbon dioxide and oxygen are normal. The arterial pressures are normal. Or is the metabolic rate control if the CMRO2 is increased due to pain, seizures, and because the patient is febrile? Are there any potential vasodilators in use like nitrous oxide, volatile agents, nitroprusside, calcium channel blockers? Or we may not be knowing there may be unrecognized mass lesions like hematoma, pneumocephalus, or if you have inserted a ventricular drain that may be clamped. So all this type checklist should be done if there is intraoperatively tight brain. So how do you prevent tight brain is maintaining euvolemia, sedation, analgesia, anxiolysis, head up position, no compression on the jugular veins. Osmotic agents like mannitol or hypertonic saline can be administered. Beta blockers or clonidine or lignocaine to maintain the hemodynamics. If there is vasogenic edema, steroids. Adequate hemodynamics, maintaining the mean arterial pressure, CVP, pulmonary capillary wedge pressure, heart rate. Adequate ventilation to maintain the PO2 more than 100 and PCO2 more than 35. Intrathoracic pressures are low. Hyperventilation before induction. Use of intravenous anesthesia agents for induction and maintenance in case of tense brain. If there is already a tight brain, what are the methods to rapidly reduce the ICP and the brain volume? So you can decrease the PaCO2, but not less than 25 millimeters of mercury. One must take care that the PaCO2 should not be reduced because it can cause ischemia due to vasoconstriction. A CSF drainage can be done where the surgeon can insert the brain needle into the ventricles. Diuretics like mannitol can be administered. You do the CMRO2 suppression with barbiturates or propofol. Mild controlled hypertension, which will decrease the cerebral blood flow, and if the autoregulation is present, which will decrease the cerebral blood flow and ICP. When there is controlled hypertension, there is a vasoconstrictor cascade which is initiated, and that will decrease the cerebral blood flow and ICP. And if all these measures fail, then you may have to do lobectomy or removal of bone flap. As I told you, sometimes intraoperative neuromonitoring may be required and the anesthesia technique needs to be monitored. Now, what is intraoperative neuromonitoring? The use of electrophysiological methods to define the critical neural structures and to monitor their functional integrity. Why you need to use intraoperative neuromonitoring is potentially to reduce the risk of injury to neural structure, identify the changes prior to irreversible damage. And the goal is maximal functionally safe surgical resection. Now, what are the common areas of the eloquent cortex which may require intraoperative neuromonitoring? The left inferior frontal lobe, the superior temporal lobe, and the angular gyrus for speech and language function. Bilateral posterior frontal lobe for voluntary movement because the motor cortex is there. Bilateral anterior parietal lobes for tactile sensation where you have the sensory cortex behind the central sulcus. And bilateral medial occipital lobe for vision where you may need to do visual evoked potentials. Now, what are the various methods of neurophysiological monitoring is by mapping or monitoring. You do mapping for the sensory motor cortex for tumors located in the frontal or parietal lobes and or which are encroaching upon the sensory motor areas by direct cortical stimulation. What does direct cortical stimulation do? It identifies the edges of the motor cortex and limits the motor injury. And the sensory and the motor cortex, how to identify them? By using median somatosensory evoked potential phase reversal. In the next slide, I'll tell you what is SEP phase reversal and how the sensory and the motor cortex are identified. And if you want to continuously assess the functional integrity of the neural structures, then you have to do SSCP and MEP monitoring. Now, this is how this phase reversal is done and phase reversal occurs and how the sensory and the motor cortex is identified. The SSCPs are directly recorded from the subdural strip electrodes that are placed perpendicular to the presumed location of the sulcus. So you assume that this is the location of the sulcus. You directly record the SSCPs from the subdural strip electrodes. And when there is a reversal of polarity of the primary cortical response, that means that is the central sulcus. So if you see between 2 and 3, there is a reversal of the polarity, and this is where the central sulcus is identified. Now, what is evoked potential monitoring is integrity of the neural pathways assessed by applying the electric stimulation at one end of the pathway with the response measured at the other end in the form of potential difference. They expect evoked responses come within a certain time from stimulation, and this is called latency, and they have certain strength, and this is known as amplitude. Any major decrease in amplitude, increase in latency, or change in patterns such as possible neural tissue compromise. Now, sensory evoked potential monitors the functional integrity of sensory pathway. What you do is you stimulate the peripheral nerve, such as common peroneal nerve at the knee or the posterior tibial nerve at the ankle, and the EEG activity is averaged and recorded at the somatosensory cortex. These are known as cortical SSCPs, and motor evoked potential monitor the motor tract function. You stimulate the motor cortex, produce motor contraction, and responses are recorded in the peripheral muscles. The MEPs can be elicited either by transcranial electrical stimulation through the scalp or direct electrical stimulation on the brain. Now, we must know when the SSPs and MEPs are done, what are the anesthetic effects on this evoked potential. The anesthetic effect on somatosensory evoked potential, that volatile anesthetics produce a dose-dependent increase in latency and decrease in amplitude. Up to 0.5 Mach of volatile anesthetic, it is compatible with SSCP monitoring. Intravenous anesthetic agents have minimal effects on cortical SSCPs. Etomidate and ketamine can increase the SSCP signal amplitude. Muscle relaxants suppress the EMG activity and improve the SSCP recording, but one must remember that neuromuscular blockage will obliterate the motor evoked potential. Continuous infusion of opioids are compatible with SSCP monitoring, but bolus doses of opioids suppress the SSCPs. What are the anesthetic effects on MEPs? MEPs are extremely sensitive to the inhibitory effects of volatile anesthetic. Doses even as low as 0.25 to 0.5 Mach can suppress the synaptic transmission. Nitrous oxide has a synergistic effect on amplitude depression when combined with other anesthetics. So avoid nitrous oxide and muscle relaxant when you're doing transcranial MEP monitoring. Intravenous anesthetics suppress MEP responses much less than the inhalation agents. So total intravenous anesthetic, like this propofol with opioid, is recommended for optimal monitoring, which have minimal effect on the evoked potential. There are certain physiological parameters which will alter the SSCPs and MEPs, and therefore intraoperatively physiological and pharmacologic steady state should be maintained for optimal SSCP and MEP recording. And what are these physiological parameters which will reduce this evoked potential? They are hypothermia or hyperthermia, anemia, hypotension, hypoxia, and hypocarbia. So if there is any intraoperative neurophysiological changes, as I've already told you, if there is increased latency or decreased amplitude or complete loss of waveform, this should be immediately reported and corrective measures should be taken. If there is a loss of waveform or decrease in amplitude or increase in latency, so what are the role of the neurophysiologists, the anesthetists, and the neurosurgeons? So the neurophysiologists can repeat the trial of intraoperative monitoring tests, check the electrodes and connection, confirm the impedance and stimulating and recording electrodes, optimize the stimulating parameters and setting of the machine, rule out there is any artifact or noise, assess the pattern and timing of changes. As the anesthesiologist's responsibility is to ensure there is no inadvertent administration of bolus drugs that can affect the evoked potential, check for extents of neuromuscular blockade and paralysis. Sometimes you can use one or two top responses to monitor the evoked potential. So see to it that when you are using this your top responses of one or two, see to it that there is no this deep neuromuscular blockade. Check the neck and extremity position, especially if there's unilateral signal loss. Optimize the mean physiological parameters like mean arterial pressure, hematocrit, pH, PCO2, and maintain normothermia and normoglycemia, which can all affect your evoked potentials. Neurosurgeons can evaluate any maneuver like surgical retraction is leading to this impairment of the evoked potential monitoring or loss of waveform. They can consider suspending the surgical procedure and observe any recovery of intraoperative signals, irrigate the field with warm saline or percaverin, and if in spite of all these measures, there is loss of waveform or impairment of the response, then for perioperative imaging can be done for further assessment. As I've told you, most anesthetic agents produce dose-dependent depression in synaptic activity, inhalation agents more than IV agents. It's important to ensure stable anesthetic environment prior to recording a baseline signal and not to alter the anesthetic technique, including the depth of anesthesia throughout the procedures. Hemodynamic parameters should not be manipulated with anesthetic agent, but with vasoactive drugs. During MEP stimulation, one must remember that muscles for mastication are activated and can result in bite injury. If the bite blocks are not meticulously placed, avoid bolus administration of drugs which can cause signal loss. Anesthetic agents with rapid onset and minimal effect on evoked responses are used. And if there is any signal loss, convey the monitoring team. If there is a loss and if you have change your anesthesia technique or use the bolus administration, convey this to the monitoring team. Now, it's important to have a smooth and early emergence for early neurological assessment. Coughing and straining can increase the intracranial pressure and lead to hematoma formation. Even hypertension during extubation can lead to intracranial hematoma formation. So you can attenuate this cardiovascular response by use of beta blockers, intravenous lignocaine, alpha-2 agonists like dexmedetomidine, ensure there is adequate analgesia, and avoid postoperative nausea vomiting by administering antiemetic drugs before extubation. When will these patients require postoperative ventilatory support? If the preoperative GCS is less than 9, if there is high postoperative risk of brain edema, raised intracranial pressure, massive transfusion, if the surgery has been close to vital structure and surgery is associated with significant brain ischemia like long vascular clipping times and extensive retractor pressure is used. What are the causes of delayed awakening? If there's preoperatively low GCS, surgical complications, large tumors, cerebral edema, residual anesthetics, hematoma, metabolic and electrolyte disturbances, pneumocephalus, residual hypothermia, or there is vascular injury which can cause ischemia or infarct of the brain tissue. I have told you that the motor mapping may be performed with the patient awake or asleep, whereas the language mapping, which requires a calm and cooperative patient, is always done with the patient awake. So if you're doing a language mapping, you need the patient awake. So just a few slides on awake craniotomy. So what are the contraindications for awake craniotomy? Absolute contraindications are patient refusal, inability to lay still for any length of time, inability to cooperate. Relative or patient has cough, learning difficulties, inability to lay flat, anxious patient, if patient has language barriers, obstructive sleep apnea, and very small children. In the preoperative period, provide detailed verbal and written information to the patient. Patient may be helped by visiting the theater and visualizing the environment and equipment involved. The neuropsychologist should assess the patient before surgery if a lesion involves the speech and language center, and the baseline response to picture cards are assessed and recorded. Acid reflux prophylaxis, steroids, anti-epileptic, and antihypertensive medications are administered in the preoperative period. The standard ASA monitors are used. Depth of anesthesia monitoring will help us in reducing the amount of anesthetic agents administered, so it's easier to awaken the patient early. Large bore intravenous access is required, and if required, sometimes even an arterial line can be put. Now, what are the stages of awake craniotomy and anesthetic options? So you have anesthetic methods are asleep, awake, asleep, or monitored anesthesia care. During craniotomy in asleep, awake, asleep, you give general anesthesia either with an endotracheal tube or an LMA. With monitored anesthesia care, continue with monitored anesthesia care. During the stage of neurophysiological monitoring, when you're resecting the brain tumor in asleep, awake, asleep, as well as in monitored anesthesia care, the patient is woken up. During closure in asleep, awake, asleep, you can continue with monitored anesthesia care or deepen the plane of anesthesia and insert an LMA. In monitored anesthesia care, continue with monitored anesthesia care. Monitored anesthesia care from propofol and remifentanil and dexmed remifentanil administered via target control infusion, and dexmed can also be used. It's important that the patient tolerates an awake craniotomy, and this relies on effective analgesia of the surgical field. So bilateral scalp block or local anesthetic infiltration is given. The 7 nerves which are blocked are supraorbital, supratrochlear, zygomaticotemporal, auriculotemporal, greater occipital, lesser occipital, and the greater auricular nerve for scalp block. Now, what are the adverse reactions of scalp block? There can be awake craniotomy. For awake craniotomy, there can be either focal or generalized convulsions, seizures, which are most likely to occur during cortical mapping. So how do you treat these convulsions? Is irrigate the brain tissue with ice cold saline. Occasionally, one may require benzodiazepine, anti-epileptic drug, or resedation, and airway control may be required. Airway control can be quite challenging as the patient's head is fixed in head pins. So insertion of an LMA may be easier than orotracheal intubation. The other complications are airway obstruction, hypertension, nausea, and vomiting. So to conclude, what is the take-home message is maintain the anesthesia for supratentorial surgeries, maintain the cerebral homeostasis, preserve the cerebral blood flow, autoregulation, as well as cerebrovascular reactivity to PaCO2, minimize the need for surgical retraction through the use of chemical brain retraction concept, early neurological awakening, thus allowing immediate postoperative neurological assessment. If there are any complication or delayed awakening, you can diagnose the complication by immediate CT scan and postoperatively ensure that the patient has adequate pain relief, prevent postoperative nausea, vomiting, and also the hemodynamic control is important in the postoperative period because there are chances of hematoma. Thank you.
Thank you, Dr. Anita Shetty. I think you covered this whole topic really very well. I don't see any questions coming up in the chat box. I'm waiting for some questions. And meanwhile, we are very lucky to have been joined by very senior anesthesiologists, Dr. Dhaigude Madam, Alka Madam, Dr. Naik Madam. And I can also see Dr.
Parak.
I think I saw Dr. Parak, but I don't see him now. I don't know whether he's there or not. Madam, any questions or would you like to have any comments, Madam?
Anita, can I say something? Yeah.
Yes, madam. Yes.
Anita, excellent presentation.
Thank
Nice,
you,
you have given the essence of the whole subject.
Oh, thank you,
Excellent.
madam.
I just wanted to ask you, you were talking about alternate sodium chloride and ringer's lactate, but you don't like to use plasma light, which...
That's what, madam. If actually what happened in our setup, now plasma light is not routinely available. Then what we do is alternating solution of ringer lactate and normal saline. Because usually whatever is available on schedule, we use it, madam. We cannot prescribe to patients. So sometimes we get it, sometimes we do not get plasma light or cabilite or something. That's why I said balanced salt solution like cabilite and plasma light, which is isoosmolar, is preferred. But if you don't have, you can use alternating ringer lactate with saline.
And another thing is, instead of remifentanil, you are using fentanyl?
Yeah, we don't have remifentanil. I think soon it will be coming, but we use fentanyl, madam.
Okay. Because you didn't mention there, you had mentioned only remifentanil.
Okay, sorry, madam.
So, yeah. Excellent presentation. Very good.
Yeah, thank you, madam.
Dr.
I'm
Anita,
sorry, there were some spelling mistakes. I'm sorry for the spelling.
I wanted to ask you that, do you think that since you had already enumerated a lot of side effects of using volatile anesthetic agents in these neurosurgical cases, do you think that TCI does have a major role to play now?
Definitely. I'm sure it has, because TCI you can give exact drug dosage like the effector site concentration. So I think if you maintain a BIS of 40 to 60 with target control infusion, I think the recovery is also good, and even during the awake craniotomy when you're using the asleep awake technique, so it's easier to make the patient awake. Definitely it has a role rather than arbitrarily giving 100 to 150 mics per kg of propofol.
And in this sleep awake thing, when you're there asleep, you do not give them any muscle relaxant. You just give them...
No, only propofol. We don't have remifentanil, so we use propofol and Dexmed.
Dexmed infusion.
Yeah, infusion.
And you do not put anything for the airway, right? It is just awake with a scalpel.
Yeah, you can use LMA. But otherwise, we usually don't put this thing. You can just put a nasopharyngeal airway and, use oxygen.
Have you found that there are a lot of conversions back to GA complete because the patient is, you may have explained the patient earlier, counseled him well, but...
Actually, I have not done many awake craniotomy. Whatever awake craniotomy I have done in KM has been awake only.
Okay.
Only initially when you're giving the block or something, that time the patients may complain of pain, so we give little propofol. After that we have not given. Actually, most of them have been awake, total awake.
Is there anybody else who has any comments or questions?
Yeah. Anita, congratulations,
yes,
beautiful presentation, huge topic you covered in 47 minutes. I just want to ask you one question. Your choice of mannitol or hypertonic saline, does it depend on the preoperative this thing, when you say MRI or CT, the size of the tumor, the midline shift? Suppose there is more than 5 millimeter midline shift and a huge tumor, whether you use mannitol or
actually we routinely use mannitol only.
Okay.
Yeah.
Okay. And
hypertonic saline does have a role, and especially I think in patients with traumatic brain injury,
and also hypovolemic, like excessive starvation, restricted fluid therapy.
Definitely, it has a role.
And another one question I want to ask you that in the tight brain, when there is tight brain, when you are using, when you are using inhalational agents and nitrous oxide, suppose you are using, there is a loss of CO2 reactivity. So no matter how much hyperventilation you do, it is not going to help. So you bring down the MAC value less than 1.5, and then you stop nitrous oxide, and after some time you start.
No, what we do is usually, madam, we switch over to IV infusion. If the surgeon complains of tight brain or there is tight brain, then we switch over to intravenous anesthetic agents, madam.
So I think Madam has gone, her audio is off. No, Anita, I didn't want to, I didn't
Yeah,
understand.
yeah.
You have time
Sorry.
to go back to intravenous agents, like you give propofol or.
As I told you, the preoperative only, there are factors which will predict intraoperative. Then you can give from beginning only Tiva. Okay, use propofol, Dexmed. But if intraoperatively there is nothing has happened, but suddenly the surgeon complains because of any factors which causes tight brain in the intraoperative period, then in spite of hyperventilation and decreasing the concentration, then we switch over to total intravenous anesthetic agent. I use propofol usually.
I think dexmedetomidine is a wonderful drug for
Yes,
supratentorial surgery.
Yes, yes.
It decreases CBF, CBV, ICP, and it is also
and very
neuroprotective.
stable hemodynamics also.
Yes, yes. And just want to this thing. When I give scalp block, 45 minutes before I apply Emla cream.
Acha. That is actually,
the patient doesn't get the pain at all.
At all, yeah, I know.
Yeah.
That is
and
true.
Especially in posterior fossa surgery or something like that, the dura is supplied by the C1, C2, C3. So when you are giving scalp block, even that pain, dural resection pain is not there. Rescue analgesics are less. Anesthetic requirement is also less. And yeah, so scalp blocks plays a great role in any
especially, madam, in the post-operative, like I had a student who did a study on with clonidine in scalp block. So the post-op analgesia was for almost 20 hours. Actually.
Oh, how much did you add? How much clonidine?
2 mics per kg, madam.
2 mics per kg. Oh, that means suppose 70 kg means 140.
Yeah, not 140 mics. Yeah,
isn't it too? Isn't it very high dose? No.
Madam, as an adjuvant, you can use 1.5 to 2 mics. Okay. Even in docs, they use, madam.
So your total analgesia time is 20 hours. Okay.
Yeah, yeah. 20
so very good hemodynamic stability.
Very good stability, and even the post-op analgesia is very good, and the requirement is also very less in the intraoperative.
Yes.
It doesn't cause bradycardia?
No, no, madam. In the scalp block, when we have used, it did not cause any bradycardia, madam. Like she had done almost.
And if you use with this clonidine on in the scalp block, and if you have used Dexmed,
then I don't use. In those cases, I don't use Dexmed then.
Okay.
That's what I mean. I wanted to ask.
The synergistic effect can have problems, no? So
and your Dexmed is your standard infusion, like 1 to 2 microgram as your bolus and 0.5 to 0.8 infusion, correct?
Yes, yes.
Okay.
Very good presentation.
Fantastic.
Excellent. Excellent.
Here so many points, and I'm sure, I don't know if our residents would like to, anybody would like to comment. I hope it's clear to all of y'all, because we really don't have much of neurosurgical work at our place. So, I mean, I think the way Madam has described the whole thing, it was as if we were doing a case, and what all would you do? It was very, very loose. You have any comments? At least Grish Candy students, please pick up.
You know, Anita.
Yes, madam.
To prevent the tight brain swelling, it starts from preoperatively from the ward only. No, actually, you know, I'll give you an example. If patient comes from cranioplasty, suppose a patient is coming from cranioplasty, on the previous day you see him during pre-anesthetic evaluation, a beautiful concave depression is there. You can feel all the borders of the bone also. But in the morning, you see when the patient comes to the theater, there is a like a balloon. Like patient has tachycardia and hypertension because of anxiety. There is swelling. So what I need to say is that mild anxiolysis and good rapport, you know, like good counseling.
So good counseling, definitely.
Yeah, and the prevention of hemodynamic changes occurring your 3-pin holder. No matter what you do, how deep you take, but it is still there is going to be the tachycardia and hypertension. So only the scalp block blocks it.
Yes, madam. Scalp block is very good actually.
Yes.
Because very stable hemodynamics.
Yes.
There is a question asked that do you add dexamethasone as an adjuvant in the scalp block?
Actually, no.
You don't use Dexa at all. So it is just plain lignocaine and
I usually play, lignocaine and bupivacaine, 0.25% bupivacaine.
you use a combination.
There is one the study which we have done is with ropivacaine also.
Okay.
Yeah.
So
How much you give ropivacaine?
Pardon, madam?
How much? What is the dose you give ropivacaine?
Ropivacaine 0.375%.
Same, yeah. As sometimes, like one small point, like I never allow the surgeons to infiltrate with bupivacaine. Xylocaine, they can do it. Intravascular. Yeah, because they never, they are very resistant to aspiration. So intravascular bupivacaine can give rise to heart block and cardiotoxic, also hypotension. And sometimes it is very refractory also, so we don't allow them to inject, infiltrate with bupivacaine.
Yeah, we only give lignoadrenaline to allow them
Yes,
to.
yes.
That is true, madam.
there's a question being asked, is craniotomy, when it is done under general anesthesia, that time also is scalp block routinely given?
Yes.
Yeah. Yes, for craniotomy only.
Okay.
Not only awake, that's what I said. My student thesis, one was clonidine for under general anesthesia and one was with ropivacaine. Then one more I did was with levobupivacaine and this thing, bupivacaine.
But all were craniotomy which were
under general anesthesia.
but you did give an adjuvant as the scalp block for postoperative?
No, only for this patient with bupivacaine, that was with clonidine. And ropivacaine with bupivacaine comparison, and this levobupivacaine was again a comparison without any adjuvant.
Right.
These studies which were done, but it was general anesthesia.
Correct. And this one has asked, Madam, hope the scalp block is done after induction.
Yeah, except for awake craniotomy, after induction.
Otherwise, Madam did say that she applies EMLA cream if at all.
Yeah, that is
for awake craniotomy.
I think. I'm just answering that gentleman's question.
Yes.
Okay. Anybody has any other questions? So I think, Dr. Nayak, anything else, Madam?
No.
Can give her
covered everything beautiful. Done it very nicely.
Very nicely. Thank you so much for spending this 1 hour.
Kalpana, thank you all the madams. It was a pleasure.
It was so nice to have you. Thank you so much once again. Yeah.
Thank you.
Thank you.
Everybody, good night. Bye-bye.
Good night.
Bye.
Thank you.